healthcare services and to make or to improve the standard of health of human beings around the world. Nowadays, healthcare is largely dependent on machines, on technologies, up to the point where we're now entering into the usage of more extensive usage, just say, of digital technologies in the world of healthcare and health promotion. And with that in mind, or with this comes a lot of dilemmas, a lot of challenges, ethical challenges, or challenges related to also the right of the right to health. Sorry. And with that in mind, and this is through this panel discussion, we aim to shed some light on some of these challenges and how can digital health serve to actually promote and fulfill the right to health. And for that, today we are joined by a distinguished set of panelists, a distinguished set of speakers that I would like first to introduce. We have Dr. Tlaleng Mofokeng. Dr. Tlaleng is the current United Nations Rapporteur on the right to health. And she has a working experience, a working background in SRHR. We also have Dr. Marco Bardus. Dr. Marco is an assistant professor at the Department of Health Promotion and Community Health at the American University of Beirut. And we also have Dr. Tammam Aloudat. Dr. Tammam is a senior strategic advisor at the Access campaign in MSF, Médecins Sans Frontières, or Doctors Without Borders in English. And we also have our very own officer at the World Health Organization, Iris Blom, joining us as well. So with that, I would first of all direct, let's say, the discussion or the opening statements towards Dr. Tlaleng to perhaps give us some reflections on the right to health and the situation of the right to health nowadays around the world. Dr. Tlaleng, can you hear me? I think you are on mute if you're trying to speak.
Good evening, colleagues. Thank you so much for this invitation to spend some time with you. Not so long ago, I was a medical student myself, so I still remember very vividly all of the different challenges that go hand in hand with being a medical student. And one of the reasons why I agreed to be on this panel, even though I've just been recovering from surgery myself, it's because I know the importance of having medical curriculums and medical institutions that are able to provide us with the necessary medical education, but I think more importantly, a human rights perspective, so that we become clinicians who are, in the very way that we practice medicine, are defenders and protectors of human rights for all. Now, the right to health contains both freedoms and entitlements. Freedoms include, but not limited to, the right to control one's health, the right to information. The entitlements also include the right to underlying social determinants of health that provides equality of opportunity for people to enjoy the highest attainable standard of health. Now, the right to health exists along other rights, such as the right to reproductive health, bodily integrity, safety, and security. And it's very important when we speak about the right to health to talk about the fact that it has to be fulfilled not only if people meet certain criteria, but there are rights that have to be fulfilled, protected, and promoted for no other reason but because people are human beings. And COVID-19 is showing us that even at our best as a global health community, we were not really prepared. For example, COVID-19 specific testing capacity, access to treatment, and a lack of consistent supply of clean water in some of the communities crucial for the prevention of the virus spread continued to be structural deficiencies. And the pandemic continues to highlight these different structural fault lines that have existed. And currently, inadequate resourcing of community health systems, the biomedical development, public information dissemination globally, the filled with many problems. And many health systems have failed to adequately provide supplies for personal equipment for healthcare professionals. And in South Africa, in fact, medical students were asked to come back on campus as they were needed to support the public health response. And there's a lot that can be said about that as well. And we know that public health professionals are the backbone for many years in many countries for already fractured and ailing public health systems. And the anxiety, of course, and the trauma that many healthcare providers and allied health professionals are experiencing at the moment is unprecedented. And the question for me is, how long can they offer quality care if they themselves are experiencing rights abuses in the workplace and continued lack of urgent occupational health as well as mental support? Now, inequality, of course, shapes structural and systemic challenges that are borne unjustly by individuals, and it's through differential access to healthcare and underlying determinants of health, socioeconomic and other structural factors that interact with each other to generate and reinforce negative health outcomes that disproportionately affect certain populations. And we know that in any situation, the disproportionate negative impact affects those who are already in vulnerable situations, who are already experiencing marginalization through laws and policies that are exclusionary. And of course, we have to pay attention, to people who were already, even before COVID, were experiencing neglect and lack of access to health services, goods, and facilities. And I'm thinking of populations of groups such as women, sex workers, disabled people, older persons, internally displaced people, people experiencing homelessness, migrants, LGBT and gender diverse persons, fellow Africans, and people who use drugs. And it's very important to remind us all that as clinicians, these types of people in vulnerable situations are the ones that, we need to be really vigilant about any policy changes, but also any practices in the medical field that can further marginalize them. And as part of our role as the United Nations Special Rapporteur on the right of everyone to the enjoyment of the highest attainable standard of physical and mental health, I'm intentional on bringing the international human rights space a deeper understanding, right? And this discussion today about digitalization of health, is it an underpinning the right or deepening inequities, is a very important question. And I think all of us must commit to gaining a deeper understanding on the negative impact of coloniality, racism, and oppressive structures that are embedded in global health architecture currently, because we know that even though in many countries, digital health and interventions and innovation is something that's being spearheaded, if we don't pay attention to the existing structural fault lines and oppressive structures, we may replicate them in digital health. Now, my area of expertise is sexual and reproductive health, and we know that sexual and reproductive health rights are an integral element of the right to health. And there are many women, even before the pandemic, who are facing obstacles that are interrelated, entrenched, and operating at different levels in clinical care, at the level of health systems, and of course, in the underlying determinants of health. And it's very important to understand that the needs are very different for different groups of patients and individuals, but also the fact that many countries are experiencing lockdown restrictions in terms of freedoms of movement, that has led to somewhat a decrease in accessibility of healthcare facilities, screening, treatment of STIs, post-violence support, access to contraceptives and safe abortions. And so the use of technology and digital innovation and interventions have been key in this period as we respond to COVID. And the context is important. If you're thinking about digital surveillance, monitoring and facial recognition and how those technologies have been implemented in policing, we have to be careful, right, in terms of how those same systems are being used in health innovations that may perpetuate racism and therefore embed racism in health technology. And if digital interventions are left unchecked and unchallenged, they will likely lead to artificial intelligence in health programs that continue to themselves cause marginalization and vulnerability. And we know that digital and advancements and technology is not neutral, and that the discrimination which leads to unjust outcomes to diagnostics investigations, analytics, and algorithms in healthcare, we need to pay particular attention to. And just to reference a really good document, it's called the Youth-Centered Digital Health Interventions, which is a interagency framework developed by the WHO, UNICEF, UNFPA, and UNESCO. And it's a really great guidance in terms of the principles on effective planning, development, implementation of digital solutions to really address many health challenges. And I think it's important to draw on experiences, past experiences of many organizations and individuals working in this field, but also as young healthcare professionals and doctors of the future, you need to be leading in building on existing knowledge and tools. And I think it's very important to see yourselves as more than just clinicians and people who are only involved in delivery of care, but it's important that you are there in the design processes, the development processes, and the research process to make sure that you are creating and implementing and sustaining thoughtful and effective digital health interventions. And it's a very important tool as well, because people who are new to this digital health discussion can use it as a start to finish, right, on how to collaboratively and responsibly develop digital health interventions. And I think all of these interventions have to be rooted, right, and supported by a human rights framework so that we don't get to a point where digitalizing health causes inequalities. And of course, you know, when you're talking about, you know, the UN, and of course in my role the special rapporteur, there are many things, and the mandate is quite broad. But in just for me sharing my vision, I am driven by the ideal of restoration of dignity, and the identification of the contextual changes that are needed to remove obstacles, oppressive systems, and conditions that make people vulnerable to the right to health violations. And therefore, I support any intervention and solution that aims to bring not only just services, but also information to people. A lot of young people don't know what their rights are. I'm an SRHR specialist, and so my entry point and my lens into many of these issues are through that point, you know. And I know in SRHR, many people, before they can even access services, there's a lot of stigma and societal pressure that you know, make people find it easier or harder to actually present to a healthcare facility. And if they can access information, access telehealth or virtual consultations, that may in fact, you know, lead to more uptake in terms of contraception and other safer sex tools. And just so in closing, I think it's important for all of us as clinicians, as future leaders, to have a collective vision for the world and communities that we want. We must uphold human rights and use intersectional frameworks as a bridge to justice, so that any intervention that we come with, whether it's digital, whether it's clinical, whether we are merging the two, you know, that we are driven by the restoration of dignity and protection of dignity of people. And whether it's before, during, or and after public health crisis or any other situation that places people in vulnerable situations, the right to health, including the right to sexual and reproductive health rights, must be promoted and protected as an integral element of the right to health. Thank you so much.
Thank you so much. Thank you so much, Dr. Tlaleng. And thank you so much for this entry and linkage between the right to health and digital health, or like the concept of digitalization health and using digital technologies. But before diving further into the rights aspects, I would like to now direct the discussion to Dr. Marco and to get to know more a bit about what is digital health. What are we speaking about when we say digital health or using digital technologies in health? So with that, I'm giving the floor to Dr. Marco.
Thank you. Can you hear me? Can you hear me well?
Yes, very well.
So I apologize, I came a bit late. I was teaching health communication and the Master of Public Health here at the University of Beirut. So the topic of today was about risk communication and COVID-19. So kind of very much related to the pandemic, the issues related to communicating risk, communicating novelty, communicating new things. And this is one aspect of digital health, the fact that we are managing loads of information, and also I would say misinformation, disinformation on social media platforms, for example. This is one of the so-called infodemic, one of the problems that we're facing. Or the digital health as a broader term to encompass different aspects that we can consider. One of the elements that, for example, in the pandemic has been increasingly used is telemedicine, and probably you can tell me more about it yourselves. So how, the digitization, the forced digitization of interactions, computer-mediated interactions between patients and providers, between providers with the same team, nurses, doctors, has to go through a computer, through chats, through Zoom meetings and things like this. This, of course, has also implications on our mental health, and this is something probably a growing pandemic underlying the conditions that we're currently living in. So it's not only an issue related to the virus itself, but it's about what are the consequences on our lives. Digital health has, increasingly been used or expanded in the past, I would say, 20 years. The attention of the research community, of the clinical medical community, have also increased because the potential of how to reach out to patients, how to reach out to different populations. However, with digital technologies, as my predecessor was saying, there's always a risk of isolating someone or creating some sort of discrimination because of lack of access or limited access to technology, limited availability of systems, or internet access in some countries might be lacking. And another issue related to literacy or literacies. In my courses, we talk about the so-called digital literacy model of e-health literacy model. E-health is another term that is used to define digital health. And according to a model by Norman and Skinner, developed in 2006, so quite a long time ago, e-health literacy encompasses 6 domains of literacies. One is information literacy, the ability for us to understand and to retrieve information from sources like PubMed, Google Scholar, and so on. And this is a skill that information specialists, librarians, know very well, but this is not common. Okay. Another domain of literacy is basic functional literacy, the ability to read a text and to understand. So this is where language plays a central role. If you use the wrong language, we might not be able to communicate and to transfer information that we want. Another element of literacy in the e-health literacy model is scientific literacy. It's the ability to understand scientific text. And if you come from different disciplines, like I have a PhD in communication sciences, of course I can understand, I can read through a paper on physics or a medical paper, a paper done by doctors, let's say, but I might not understand completely the meaning and how to interpret the data. And this is where we need to translate that knowledge into something more concrete. Knowledge translation is a key word here. Another literacy is the ability to use technology, so the ability to understand and how to make sense of devices, so the phones, computers, cameras, and so on, Internet of Things, how to make use of those technologies in order for us to process information related to health. And then this is the segue to another literacy, health literacy. And probably this is something that is not completely new to you, but health literacy, by definition, is the ability to understand and process information related to health, and it is context specific. So we cannot be experts in all matters. You are doctors, so you have a broad knowledge of health, but not as much as patients have. So we need to probably address these aspects in the way we communicate health, even through digital technology. Another problem of digital technology and e-health is access and acceptability. So once we have access, we have to ensure that people actually accept the technology, accept the use of that. And we cannot just say, oh, we need to use technology now, that's the only way we can do it. We have to find a way, I'm talking from a perspective of a health communication specialist here, we need to find different channels to communicate health-related content. We cannot just say, oh, that's the only way we have to do, we have to use mobile phones. The assumption that everybody has a phone might not be tenable for everyone. So we are not we're just endangering equity of access. Last point is about quality, of course. So communication content in digital health should be curated, should be managed to control. Of course, different international organizations are trying to talk about the importance of verifying sources, verifying the quality of information, because we are dealing with a lot of disinformation out there. And you know very well the problems that are arising from people asking you questions about treatment, vaccines, about different solutions that can come, from dealing with different health issues, including COVID-19. So we need to, as healthcare professionals, we need to be cognizant of these problems. We need to say probably be activists. So something that probably your association is doing more at the policy level in ensuring the availability of digital resources that are there. Most of us can access them. If the resources are not available, we need to find a solution to reach those who are not, they are not reached. Access is providing access for free for everyone. That should be the ideal for every country in the world. This way we can ensure that really digitization is really for everyone, it's free and accessible. Acceptability, this is something where we health communication professionals can work on trying to create content that is contextualized, acceptable because it's in the right language, not only in the right language linguistically speaking, but it's also in without jargon, with the specific guidelines that they following for clarity, being succinct, being clear, and so on. We can also think about persuasiveness using this digital technology. This is something that we are working on. And then last but not least, of course, quality of content, quality of information. We need to double check the sources are clear and they are available to everyone. I think, more or less this is what digital health is about. And so we are considering different aspects from the media perspective, from the communication perspective, from a medical perspective. We need to put together different views to work together for the same goal, which is improving people's health. I hope this addresses the overarching question.
Thank you so much, Dr. Marco, and you highlighted a very important point that I would like also to drive the discussion towards Dr. Tammam from this point. So Dr. Marco highlighted the importance of resources, the availability of resources, and also health literacy in terms of promoting, let's say, the usage also of digital health, digital technologies and health overall. However, when we look at humanitarian settings, when we look at vulnerable settings, Dr. Tammam, is this something realistic? What does digital health means for humanitarian and vulnerable settings?
Thank you very much for having me, and I apologize, I have a cold and sound probably terrible. Thanks for both speakers for talking about the right to health and what is digital health to start with, and both are important. What I'm going to try to do in the next few minutes is argue whether this can or should be applied in humanitarian or very low resource settings. So just to put it in perspective, humanitarian settings are settings of emergencies outside the norm, and that could range from refugee camps in Greece to conflicts that have been ongoing in places like South Sudan, Congo, and others for decades now. The hallmark of many of them are the dysfunctioning. I do not like the word generally used, the collapse of health system, the dysfunctioning of the formal health system. And by that, I mean the one that is sanctioned by the government that looks like a Western health system. And I don't say generally, because there are other healing systems in most places that are in parallel to the formal health system. So you do not have enough doctors, enough nurses or other allied health professionals. Usually it's also those are also places that suffer from increased mortality and morbidity of multiple causes, both infectious, endemicity of diseases that are not treated well. So many of the emergency countries suffer occasional or frequent outbreaks of still measles in some places, malaria in endemic areas, vaccine preventable diseases, and others. There are also socioeconomic effects on health, including hunger, and there are frequent population displacement because of violence or because of socioeconomic issues. So all that, in trying to describe situations that are either emergencies or are extremely low resource settings, the idea of digital health is both tempting and a cause for caution. And I'll try to explain at least what we have done in Médecins Sans Frontières in thinking about what digital health could be in those settings. And I'll describe it in a few categories. The first one is on static digital health. That is the ability to avail resources about treatment in electronic form. Think of it as the simplest possible way, be able to have the clinical resources available for people that wouldn't have had them otherwise. This doesn't require a high level of connectivity or pretty much functioning machines. You just need a basic ability to view resources. And that goes from static in just, having a PDF on a computer. I'm sorry if I'm sounding a bit archaic, but this is what we're exposed to all the way to having resources that get updated. So you're sent a newer version of that in a form of a new PDF, or access to some of the many clinical decision-making aids that are actually in real time. This is a form of digital health that actually probably revolutionizes care in low resource setting much more than any of the other more sophisticated technologies do. The ability to know what you're looking at and find the resource to deal with it. Then there is, then there is a more dynamic kind of digital health that might help the provision of healthcare. The technical part is telemedicine, to be able to actually talk to people who provide you with more clinical support than you have. And we have used telemedicine for more than 15 years. The brilliant thing about telemedicine is that you don't need hyper specialists everywhere you work. They can connect to people that could help them. And I've reviewed hundreds and hundreds of cases and been part of them. And there is an undeniably life-saving effect to the ability to connect clinicians across different places. But there's also, this is technical, but there's also a decisional part to dynamic healthcare. And by that, I mean someone who tells you what to do, not what the diagnosis is, or what the treatment should be as a gold standard if you are, in a UK or US hospital, but what can you do and what sort of compromises are reasonable to look at, someone who helps the decision-making process of a clinician. And that is different because there are many treatments that you'd be advised on by an advisor, by a specialist that wouldn't be available for you. And I can tell you, if time allows later, of a few cases where that was the case. Now, those are supporting clinicians in being able to execute better medicine in very low resource settings where neither the resources, the physical resources to provide medicine are available, or the level of skill and specialty is available. The other ones are access to services. Quite simply, people do not know necessarily what's available and how to access it. And with the proliferation of digital technologies in many places, and I'll explain that in a second, we can share information about what services are available, how to access them, and under what conditions. And I'll talk about my experience in a place, for example, in Sokoto, in northern Nigeria. We had, that was a while ago in 2012, but every single woman who came to our hospital had a mobile phone, not a smartphone, but in one of those old Nokia refurbished, resold to Africa phones that functioned. And this wasn't a matter of connectivity, it was a matter of security, the ability to communicate. And in many places, in many low resource settings, the payment and receiving of payments through phones happened way before Europe, through the exchange of credits, telephone credits, the prepaid credits. So a lot of people had phones, and we were able to exchange both, provide mass SMS, for example, to inform people about available services, and to help them override restrictions. So in places where we've had post-sexual assault circumstances, it was very difficult for many of the people subjected to it, mainly women, but in some cases men and boys, to come and seek service. And we were able to send information widely, so undirected, so it avoids the prosecution and oppression of people seeing someone seeking the information. The last thing I will mention as a potential for very low resource settings and humanitarian settings is digital surveillance of disease. And that isn't new. We have seen digital surveillance, in my experience. Mobile phone data was used in Zimbabwe in 2009 cholera outbreak, and it helped us figure out the direction of population movement and anticipate outbreaks of cholera. In Mozambique in 2007 and 8, with the floods and surveillance imagery from satellites, helped us understand the location of communities and how did they move to be able to provide health services. There has been in 2000 multiple times, but starting in 2009 when the H1N1 previous pandemic was there, the ability, again, mobile data is valuable because it's aggregated, can be understood without breaching confidentiality of individual users, and provides valuable information about population movement. So all those are ways that could happen even in very low resource settings to provide better medical care. I will say just a couple of words about the benefits and the risks immediately, and we can answer more questions if needed. But that's more access. That is people who wouldn't receive good medical care receiving potentially better medical care, and that's a good thing. It builds on existing capacities, and it accepts that digitalization is increasing, whether it is even in the lowest resource settings, the digitalization is not static, it is improving. And when you start, you don't need to start with high tech or need a wide bandwidth, but can start with actually quite basic capacities. And it helps with, you can engineer it within the existing social, economic, and political structures without having to impose costs or burdens on the population. Now, the cons, the risks in such use of technology is that there's, as you know, I come from a place where, surveillance, observing people is not necessarily too far from the government's interest. And the use of the more data we collect, the more we have data that can be understood for purposes other than the benefit of the people who the data is collected from. So the potential for surveillance sorry, Dr. Tlaleng talked about the possibility of surveillance and AI becoming evil, and AI is affected by the same biases of the people who create it, and that's not far from being applied in AI that is concerned with medical issues, but there is another potential of increasing inequities by the fact that when I say a lot of women had phones in Nigeria, in northern Nigeria, in a very rural, very poor area. That doesn't mean everybody. And the consciousness that there is always a more marginalized, more poverty affected population means that we cannot put all our eggs in the basket of that. Even if 90% of the people have phones, there's still 10% who don't. And those are usually the poorer, the more distant, and the least serviced. So just by, there isn't a justification yet that I can think of. You know, if we do better for the 90%, then we're fine to ignore the 10%. That's not an okay position as far as I'm concerned. And digitalization carries at least some risk of doing that. We know that very well because user fees in very low resource settings that have been argued as, oh, but it's very low. We know for a fact that they have excluded the poorest populations. So I will stop here and happy to go into the discussion. Thank you very much.
Thank you so much, Dr. Tammam. And thank you so much for highlighting the applicability and dimensions of digital technologies in vulnerable, let's say low resource settings and humanitarian settings. Let's not use the word vulnerable. And I would move on from the, you mentioning the 10%, access to the 10%, and speaking about the access to the 30 or 40% of youth that represent almost 1/3 of the world population. And I will be directing this this question to Iris. Iris, Dr. Marco mentioned health literacy earlier on, and as well, let's say technological literacy as well in that aspect of using technology in health. So can we say in this aspect that youth are more privileged because they are the generation of digital technologies? Can we say that digital health is more acceptable and more appropriate to youth? Is this the reality, or are there other considerations to keep in mind?
Thank you, Mahmood, for the very interesting question. I'm very happy to be on this panel. Thank you for the invite, and I have very much enjoyed the intervention so far of the esteemed other panelists. Apologies for my camera dropping out once in a while. I'm not sure why that is. I think your question is super interesting, because when we talk about youth, a lot of times youth are referred to as digital natives, meaning that we've grown up with digital technology and we know how to use it. But I would like to underline, first of all, that a little less than half of the population in the world doesn't really have access to stable internet connection. So, and a lot of that's also youth. So when we say that youth are digital natives, maybe we're also only talking about youth in more privileged settings, because I definitely do not think it applies to all of the young people in the world. So that is one thing that's important to consider when we address that question that you just addressed. Moreover, when we talk about digital health and its application towards a young population of patients, I definitely see a lot of opportunity there. I mean, the other speakers also refer to digital health as providing many different opportunities for patients as a whole, and I would add to that I see opportunity for every single age group, if I can address it that way, and definitely also for young people. For example, when we look at health apps and the usage of that, we see that a lot of young people are into this, and moreover, we do know that a lot of young people, indeed, maybe that privileged group of young people, is very well versed in the use of technology. So therefore, digital health could definitely be a great asset. And finally, an important point that was also mentioned with regards to SRHR is that youth seeks a lot of information online, and there's definitely a huge opportunity there, but also a huge threat, which was mentioned by Dr. Marco as well, with regards to the disinformation that is on the internet as well. So I think that's one thing that we should consider, particularly when we talk about youth. Digital revolution, however we want to call it, also causes a lot of challenges particularly for young people. So for example, cyberbullying, online safety, sharing of nudity or sexual images by young people and not understanding the consequences of that, or social contagion around self-harm, for example, even mass shootings, radicalization, eating disorders. I think those are challenges particularly experienced by young people. So that is something that we should definitely add to this conversation, especially when we talk about youth. And you know, applying this human rights concept to digital health, therefore, is essential. Also, when it comes to health of young people, definitely. I would also add to that as medical students and future health professionals, we are also young people, and I think more broadly young people because of our backgrounds and because of how we can use technology. It's essential that we are part of this development of digital health, but moreover, I think in order to avoid the issues that I mentioned earlier, it's also essential that technology and the use of digital technology is part of education for young people, so that we can avoid those issues going forward as well. So that would be my answer to that question.
Thank you so much, Iris. And I would take it from the last point, from education, and also from a point you mentioned, information, the curiosity of youth. So information, data, research is sadly controlled or more in the hands of the most privileged, let's say, in the world. And in light of the inequitable distribution of resources and investment and also research, so I would direct this question first to Dr. Marco, but perhaps we could listen also from Dr. Tlaleng. Does the digitalization of health actually contribute to health equity with the let's say, inequitable distribution of information and data, or does it widen the health gap?
I think it's a $1 million question, but I mean, I'll try to attempt to answer this question by bringing some theoretical frameworks from communication sciences here. Two points I want to make. One is the question is about not whether we access information through digital technology, but how we access that information. And so this is one of the theoretical frameworks that come to my mind, is the usage and gratification approach. So we use technology, we use media to fulfill some needs we have. Information, you know, interacting, engaging with others, being connected. And so this brings me back to the intervention by Dr. Tammam, that Aloudat. How are people using this technology? For what reason? So the fact that they have the iPhone or the fact that they have a feature phone doesn't mean that they can use it to access information for health. I'll give you an example from my research, my work we do here with some Syrian refugees living in Beirut, in the city. So we were trying to develop a platform to promote COVID-19 or to reduce COVID-19 misinformation. We found out that most of our beneficiaries were not able to download the actual applications because they don't have the space on their phones. Even if they have internet, even if they have the phones, they don't want to because it's not what they want. Okay, they want to find information different ways. How do they find information related to health? Through chats on WhatsApp. So this is where we need to go. Now, of course, this requires our rethinking of how we create a response to that. We need to follow the needs of the people that we're serving. We don't just follow what our theoretical approaches tell us. We need to really design interventions in a more equitable way. Equitable way means to give everyone access, potentially, so to find the channels and the solutions for them. Another theoretical approach that might be very useful here is diffusion of innovations. And basically, it's a way that we can use to segment and to understand how our target groups, beneficiaries, would process information or look for information online, and how they can use that information to make sense and to use it, to solve their problems. And of course, we are targeting the innovators, so those who are keen on using technology, with the idea that if you can use them to spill over to the other segments, those who are, let's say, early adopters, late majority, and eventually to reach out to the majority of the people. However, there's always a risk, of course. If we design our intervention just for the innovators or the early adopters, yes, by definition, we leave out the rest. And this is the problem. It's an ethical dilemma, not only just a marketing standpoint. So I bring here my way of thinking for social marketing. A solution that I would use is to differentiate the offer, so differentiate the communications. We have different channels. We reach different people through technology, maybe, that would be one of the channels we reach out. But then we need to invest more resources to reach out to those who are not in digital technology and would require probably more effort in order to be addressed. We need to find design solutions according to the needs of the participants, the beneficiaries.
Thank you so much, Dr. Marco. And I would move to Dr. Tlaleng and add another dimension to the question. So Dr. Tlaleng, in light of this dilemma between achieving health equity or widening the health gap, how do we define the highest attainable standard of health in that terms? How can we achieve it with the vast differences around the regions of the world in terms of digital health services or digital health literacy as well?
It's a very important one. And I think if you look at the way that the right to health, is defined, we know that it actually goes beyond just the access to health services. It speaks also about, having access to determinants of health. And one of the important things is access to health-related education and information. And I think if the messaging and the communication is inclusive, then you have more chance of using these platforms in an equitable manner. But if you still are not thinking about, people living with certain disabilities, if your, your product doesn't have assisted, visual or auditory aids, it means you will be leaving some people behind. And so I think that's the main thing for me is how do we use digital technology in the health sector to operationalize the right to health? So how do we bring the right to health alive every day in our clinical care? And I do think it holds immense opportunities, not only just for information and education, but also as affirmation, right? A lot of countries have very hostile laws around same-sex relationships, for example, around, men who have sex with men, even adolescent health. And in some states, in some instances, even criminalization of sexual and reproductive health rights. And so there are ways in which digital platforms can offer people a safer space that doesn't exist in their real life. And you may find that the online space is safer. And that's actually how I started to do my, advocacy and using social media as a tool for advocacy. It was precisely because there was certain information that was just not available to people to be able to make informed consent and protect, their own bodily integrity, but also to improve the way that they, have consultations with their own clinicians. So from that point of view, I think not only is digital, interventions important, but if you think about data, right, and patient filing systems, I think there's a lot that can be improved because in South Africa right now, we have a report by the Commission for Gender Equality that speaks about, that found actually that HIV positive women were forcefully or coerced into sterilization during the laboring process when they then required an emergency cesarean. And part of that is that they were told, because you have HIV, you have to consent to the sterilization, otherwise we won't help you. Or they were saying other derogatory things to those women. And so when you bring in the element of even just using technology in patient management systems, it means if those women wanted some form of redress, they could have found their files, because right now, many of them, the files, are missing because of the manual filing system. So whether you are thinking about it as a clinical or a clinical intervention, or you are looking at it from a health system point of view, there are many good points that can be made about digital interventions and why we need them. But we have to be careful that we don't cause further marginalization. The costs of data are very high in many countries in the developing areas.
So even the types of content that are being developed have to take that into consideration, because it's a very different uptake, between a clip that's 30 seconds long versus a video that's 14 minutes long. And so we don't want to then cause a digital divide between the classes or between those people who have access to mobile data, for example, which is why we have to incorporate things like free USSD coding and those types of other important elements. And I think digital health has to be part of a bigger system. It has to support and be enhancing what's already there, what already exists. And in my view, human rights have to be the bedrock of any digital development. Thank you very much.
Thank you so much, Dr. Tlaleng. Before moving to Dr. Tammam, because Dr. Tlaleng needs to leave, so Dr. Tlaleng, do you have any final words that you would like to address to medical students? Because at the end, they are the future healthcare workforce, and future digital health technologies or digital technologies would be at their disposal or at their usage. So what are the considerations that medical students need to keep in mind when dealing with digital technologies?
Digital technology can't replace the clinician's touch, so it's very important to remember. And for me, I found that, when I think of digital interventions as something that enhances my work and my practice, as opposed to it replacing me, there's still so much that patients require in terms of confidentiality, in terms of privacy. So remember all of those important elements, even when you are taking photos, to share with your consultant, to ask, about a diagnosis or differentials. Always keep in mind that you are dealing with humans who have rights to confidentiality and privacy. So don't tweet, about your patients. Don't post your patients' files on the internet, which is some of the things that we've seen, happening, especially with everyone, not just the younger colleagues or the interns. And so I think it's very important to have a secure back end to any digital or cloud storage, that you have. But I really do think it is a moment in time where I think medical professionals and clinicians should be leading. I find many times in public health, the clinicians are always missing at the table. You have policymakers, you have legislators, politicians, grant makers, but the people who are in charge of actually turning human rights into clinical services are often missing. And it's my hope that with you guys and this relationship we're establishing, that you can be more present, in these spaces where decisions are being made, and you can lead in terms of design and development, because at the end of the day, that product has to be useful for you. But remember the principles of medicine, remember the principles of care, and no matter what, nothing, no technology can ever replace your clinical acumen. And I think that's very, very important. And just to say good luck to all of you, and I think we should maintain this relationship going forward. I mean, I would have really succeeded if more and more medical students and nursing, as well as doctors, are vocal and are present at the table, especially when we are talking about human rights and pragmatic issues, because often people throw a lot of money at the problem and never get the desired outcomes. And it's often because we are not consulted when these programs and these solutions are being thought of. And so I'm hoping that this time around, we will never go back to a place where we are not in webinars anymore, right? Where the smartphones are not there. So not only are our patients, of course, asking us questions, but I've had patients Google what I'm saying, that the diagnosis, while they're in the consultation room with me, right? So accountability would look different. Your patients, are going to demand very different things from you. And how do you deal with that situation where you are in a consultation and someone is Googling, and using Wikipedia to then quiz you on the spot about, subarachnoid hemorrhage. Those are quite difficult, moments, but it will happen. And I think having cyber intelligence is an important aspect as a clinician, as young people yourselves, but also as people who will be leaders and who should be leading all of us as we embark on this amazing journey of digitization. But let's again ensure that we don't leave people behind or cause further marginalization because of digital media. Thank you.
Thank you so much, Dr. Tlaleng, for the final strong words, and thank you so much for joining us today. We are so happy and appreciative of your presence and of your valuable input. Thank you so much, Dr. Tlaleng. Thank you so much, and goodbye. Now, I would love to take the discussion back to Dr. Tammam, and reflecting back to the issue of information and data, and especially evidence being synthesized, or let's say uncovered in the privileged settings, or in the most privileged settings. In that context, are digital health services really for all? How can we ensure that digital technologies are sensitive to the widely varying health needs of different vulnerable populations around the world?
Oh, thank you, Mahmood. This is not an easy question. But we can. The short answer is we don't know, because most of the technology and the people who do technology exist and work out of Western settings, and are more concerned with the viability of their products. And by viability, I mean being able to sell them in those Western settings. Like other technologies that relate to medicine that are non-digital, like medicines, for example, diagnostics and so on, we end up having to adapt existing technologies to settings where they are not designed for. So let me give you an image of a couple of things that you might encounter if you are to go to truly, areas of poverty or deprivation. First, the concept of seeing a doctor is foreign to millions of people in the world. Doctors don't exist in so many places, or exist so rarely, that they aren't the source of medical care. You all know Dr. Tedros, who is the General Director of WHO. His legacy in Ethiopia is having created a system of community health workers that have the ability to manage most of the diseases or the main killers. I was many years ago, 2007, in northern Ethiopia, and I've spent some time in a small village in Amhara where one of those workers, a lovely lady, was able to actually do things beyond, basic, for someone who's trained only for months, the ratio of training to life saved is incredible. She was able to diagnose and manage several infectious diseases, provide antibiotics, rehydrate, help people with basic health needs, and refer to other health facilities when possible. So what I'm trying to say is the practice of medicine that most of you would have known as the standard isn't the standard in many places in the world. So even when there are health facilities and services, the wide variation that you'd have is in what is your function as a doctor, or as an allied health worker, a nurse, or a clinical officer. And in Western settings, there is a norm now where we don't make decisions about anything other than diagnosis and prescription of treatment. And I've read a description about what jobs would go first, when AI emerges. And one of the arguments was, doctors will disappear. You don't need them. Doctors are a biological diagnostic algorithm. And once you have a more accurate diagnostic algorithm, you won't need doctors. One of the last jobs to go would be nurses, because they have a human interaction, the ability to read emotions, all the stuff that AI aren't very good at doing. And they need to actually touch people, do things that are physically direct, and So this is our fault partially. We've allowed ourselves to become in a position where we are those diagnostic algorithms. algorithms. In Syria, where I come from, until 40 or 50 years ago, a doctor was called Hakim, and Hakim in Arabic means a wise person. And a wise person is a wise person because by the virtue of their education and exposure to the outside world, they were allowed to become arbiters of problems, conveners of opinions, practiced a moral judgment beyond just diagnosis and treatment. And that we have to do in very low resource settings, because you have to stand every day and decide who gets treated and prioritized and who doesn't. So all that is to say, there is a moral side. I think expanding on what Dr. Tlaleng was saying is, you have to accept that you have to be present in where those moral decisions are being taken, the allocation of resources and so on. Now, that translates into, in digital health too. I'm not a skeptic and I'm not a diehard fan. I am a cautious optimist. Digital health will provide opportunities for people that haven't had it before, if we as medical practitioners are cautious and conscientious. And by that I mean, let me give you a few examples where I think things can go south. I've had many discussions in the height of the refugee crisis in 2015 and 16 about, okay, what we are doing is we have clinics along the migration way from Iraq, Jordan, Lebanon, and Turkey up to Greece and almost all European countries. And we treated patients in all of them. What we couldn't do was treat patients continuously because we didn't have files on the cloud. And people were very excited about doing patient files on the cloud. So whoever gets handed over the patient have their full history. And I stood really vigorously against it. And I was called, regressive and so on. What I couldn't risk is being ordered to hand over patient files. And here's where you actually have to stand at the intersection of your patient's needs and your patient's security and your patient's ability to protect things. So, why was I worried? Because they had to pass through Greece, Macedonia, Hungary, sometimes in Poland and other places where they wouldn't hesitate to issue a court order for us to hand over the documents. And if we did, we will have to hand them over. And I would rather not have the document than have to hand them over. So this was one example. Okay, the other example is there was a question about what's the harm in having all the information out there? Well, first, it's not our decision. All the information that can go out will go out, but that we should be conscientious that includes misinformation and disinformation as well. And I was trying to paste it in the agenda, but I only have the file, not the link of I don't know if any of you has heard of a media platform called InfoWars. This is a US media platform run by a pretty comical but very dangerous propagandist who is a very good friend of Donald Trump, and he's anti everything that makes sense. So he's anti-vaxxer, anti whatever. And there is this video where a person is calling a help center and asking, okay, so does the COVID vaccine prevent me from getting the virus? And the answer is no. Does it prevent me from transmitting the virus? And the answer is no. Does it prevent the lockdowns? And the answer is no. And they are using partially extracted and misrepresented accurate medical data to create an emotion, an anti-vaccine emotion. I can't prevent that. Is the answer to put all the data about the vaccine out there? Probably yes, part of the answer. The problem with propaganda and misinformation is, you can't do misinformation with sound bites. You can't really do good information with sound bites. So to go back, all the data out there, I think probably yes, but accepting that part of our job is, and that's part of the job of the Hakim as opposed to the doctor, is be a center, be worthy of the trust that people put in you to say what you know, say what you don't know, and tell people how can they, obtain the information, what choices do they actually have. And the last thing I'll say is in Western settings, in reasonably high resource settings, we think of informed consent as a given. We think that people have a certain level of ability to understand the choices they are given, and that the system is careful enough to give them choices that make sense. That isn't the case everywhere. And part of our job as well is to interpret the choices people have into a way that is respectful, that is sensitive to the context, that is able to actually give them information unprejudiced. And that we fail to do quite regularly. So from, I've had a patient whose son had severe malaria in Niger, and she was told, we need to do a transfusion. Is that okay? And she nodded her head. Someone, that's me, French is my third language, talking to a Hausa interpreter who talked to the lady, so I don't know what she heard out of the whole thing. And she nodded her head, and I'm certain she doesn't know what transfusion is. So being able to, the availability of the data is very different from the understanding of the data. And we can't comfort ourselves by saying, oh, everything is online, so we're fine. I'll stop here and see if I can be useful further. Thank you.
Thank you so much, Dr. Tlaleng.
I think Mahmood may have disconnected himself.
Yeah, Maha, could you check if he's still here by any chance?
No, he has disconnected. I will check if he's coming back. Meanwhile, if we could take the questions from the chat box, if that's possible.
Sure, let me go to the first one. So the first question that we have here is, thank you to the speakers for the super insightful presentations. What is the link between digital health and ethical health research in humanitarian settings? So I think, Tammam, I'm not sure if you would like to speak on that question.
So I won't give a long answer. I will give you a framework that might be helpful. In BMJ Global Health, there is the editor, Shea Abimbola, who's a Nigerian living in Melbourne, I believe, has written something about who produces knowledge and who consumes it in what context. So let me paste that into, it's not exactly about research as much as it's about, the view from outside, the view from inside. What is the risk and benefit from having research done by externals for the consumption of externals, by internals for the consumptions of internals, or any other variations? And I think this gives an interesting view. In a time where we had respected physicians in France in the beginning of the COVID-19, and respected, I say it sarcastically, advocating for Africa being a test place for clinical trials on the vaccine, where we have clinical trials that are done on populations where it doesn't apply, where we think about research, and research whether data or clinical driven, without thinking about the social, economic, and political context where that applies. Any drug would not have the same effect on a well-nourished and malnourished population, for example. So just because a drug works in Europe, it doesn't necessarily work in any given other context. And just because a digital technology is favored or functional in a context doesn't guarantee that it does in another one. So I'll give you a couple of examples. In Rakhine State in Myanmar, one of the most oppressed minorities in the world, the Rohingya that you must have heard of, Facebook is the absolute favorite means of communication, misinformation, exchange of data, and everything. Twitter, I've followed Twitter in Yemen in 2014 for like literally minute by minute run of the fighting when we were trying to enter the operation. Digital data is not generalized. What we like doesn't necessarily mean it works somewhere else, and we have to accept that it's inconvenient, but the variations warrant research by people who are affected for their own consumption, and that's for it to be actually useful. Well, I think Dr. Marco would probably know much more than my sketchy information about that.
No, I think you covered it very well. I think the issue is really about how we can use that information. Again, I go back to my point, not the fact that we had access to the technology that enables us automatically to make use of that information from a health perspective, of course. So another point, I think I was reading in the chat here, other questions related to availability. So the availability of data, I wanted to comment on that. It's a matter of data protection, so and then accountability of who's in charge of protecting the data of people that are shared. I mean, when we download and we use Facebook or other social media, social network platforms, we abide by terms of references and you know, policy regulations that are defined by the platform itself. So we agree on the terms. Now, to what extent are we allowing that information to be used for other purposes? That's the question. So, I mean, I'm happily using a digital application for my patient health records. AUB has, you know, shifted to one of the popular digital platforms for patient health record. I'm very happily managing my wife, my daughter, everything is there. I like it, I enjoy it. I am also a conscious optimist about using technology. The question is then when this information is misused or used beyond my control. So we should always make this assumption that people know that the data is used for this purpose or not. So the consent is implicit sometimes. So the issue that we're raising now, there are fundamental issues of rights, not only from a research perspective, but from human rights. We need to have contextualized approaches to this issue, that we cannot assume that people have the consent. I wanted also to comment on the fact that, you know, machines will rule us, not necessarily. So AI you cannot teach AI consciousness, for now at least. You cannot teach AI ethics, and you cannot teach AI empathy. As far as I know, at least. I'm not a roboticist, let's say. But at the same time, I do believe that we need human decision makers in many decisions that were made on the digital health. And again, having the rights-based approach embedded in our question, in our development of research projects, for example, or projects, whatever they are, is fundamental. This will address the issue of access and everything else. So the framework that you guys have asked us to reflect on, the AAAQ framework, is very important to start the thinking. I think this acknowledgement is a very much the starting point.
Thank you so much, Dr. Marco, and thank you so much, Dr. Tammam. And I apologize for my internet connection issues. I think this displays one of the major issues with digital health and accessibility to digital health. From that point on, I would ask one more question from my side, perhaps two more questions, and then taking more questions from the floor. Before I went out, Dr. Tammam mentioned a very nice point, the intersection of needs and security or the intersection between needs and security or rights. And from this point on, I would take the discussion towards what does a human rights-based approach to digital health look like? Because this is basically the intersection between needs and security. To meet that intersection, we need to have a human rights-based approach. So how can a rights-based, consensual, individually private, and culturally adaptive and inclusive approach towards digital health be ensured? And I could maybe direct this question first to Dr. Marco and then to Dr. Tammam.
Yeah, thank you very much. I mean, I can speak from a small experience I have. I am the principal investigator for the Lebanese arm of a grant for mobile technology and family planning in Lebanon and Jordan, sponsored by the IDRC, the Canadian Research Foundation, basically. And the funder asked us to develop a proposal following the rights-based approach. That was embedded in the grant. Okay, so that's one way we can do things, and I appreciated a lot the input from the IDRC that helped us to design the actual project to fulfill those needs, to have our beneficiaries in mind. We cannot just design something because we want to address our research questions regardless of the approach. No, we need to have these way of thinking. Now, is this generalizable to other institutions? No, I'm not sure. But this could be one way forward. So it comes from the top. So institutions, funding agencies ask us to develop this sort of approach, having the framework embedded there. We need to justify all decisions we make using a rate-based approach. This is one way. Then the other way would be from the demand, from the offer. Let's say the researchers have to be trained in thinking this way. And this will take some time, of course. But this might be another way to say, oh, we have to remember, and you have made a Hippocratic pledge, as the professionals, to follow some ethical moral standards. The ontology, this is the key for any profession. It should be the key for any profession. So having these discussions with you, medical students, is fundamental, I think, to create a new generation of, right-based savvy people that would have already in their mindset the approach that would embed in new grants, in proposals, in projects, and in everyday practice. So I think this works both ways.
Thank you so much, Dr. Marco. And also, Dr. Tammam, we would love to take your perspective, let's say, on how can we achieve a human rights-based approach to digital health, or what does it look like?
So, thank you again. And, of course, there are specific issues to digital health, but we also have to accept that that cannot be achieved without a revisiting and a view of what ethical and human rights-based medicine should be as it evolves. And what we are doing now is, rightly, as Dr. Tlaleng mentioned, is link human rights issues of access, agency, and so on to specific programs. So she's talked about sexual reproductive health and rights, access to abortion, for example, preventative care, post-rape, and so on. Those are very specific, and those are rights-based interventions that have to be done. However, there's a parallel stream that requires us to think about medicine in general. And in my view, what my learning journey comes from having gotten out from the comfort of having guidelines and into situations where you have to do them as you go, and you have to do them to the best of your ability. And I can tell you that modern medical in education, to my knowledge, doesn't equip us to do that. It equips us to, differential diagnose the hell out of anything, but not necessarily to think about a moral dilemma very efficiently. And in that sense, medicine has moved from the paternalistic, we know better than you, to a more, or is on a way towards a more participatory thing. We accept that Western biomedicine isn't the only aspect of human health. And Dr. Tlaleng mentioned that we are going to have to avoid a continuation of the colonialist and racist legacies that plague medicine's history. But all that is to say, I don't think we can patchwork a rights-based approach to digital health or to any other aspect of medicine without going on doing that as part of turning patients into subjects of a partnership with full agency over their lives and choices. And let me just qualify that statement. This I borrow from pedagogy and education science. Education used to be that someone with knowledge imparts their knowledge on someone without knowledge, so they become more knowledgeable. That's how my school was. As teacher taught me what to know. And pedagogy in a more progressive form is a mutual process of learning that turns the student from an object that is acted upon into a subject of an autonomous subject that makes their understanding of knowledge itself. And that has to apply to medicine. Because we can't spend our time prescribing biomedical solutions to what is effectively not only biological, but social and economic and political problems. And we cannot extract ourselves outside the whole of society and politics and so on. So in that sense, what I've learned from being in a very low resource settings is that our duties as doctors include giving agency to patients, and one of the major routes towards doing that is the existing medical ethics when understood properly. And because they aren't enough, another framework of that is human rights. And I do not understand human rights in the legalistic sense. And you'll notice that people say, you know, the highest attainable standard of health, and that is undefinable because the highest attainable standard of health is different in any given country if the country is spending 40% of their budget on armament or not. So it is still a political choice. The access to data and information and digital infrastructure is different if it's prioritized by a government or not. So understanding that from the wider human rights angle is required and will not happen effectively without the participation of medical and allied professionals in that discussion at the very basic and visceral level of it. Thank you.
Thank you so much, Dr. Tammam. And I would move the discussion a bit towards Iris, still on the rights-based approach. But so Dr. Tlaleng mentioned that the use of digital technologies or digital health does not necessarily or does not aim to replace, let's say, the healthcare workforce or the human workforce, but rather it should complement it. So in that context, what is our role as current students, but also what is the role of future healthcare professionals in ensuring a rights-based approach and ethical and dignified digital health services?
Yeah, thank you so much for that question, Mahmood. I think it's a very important one, as we've heard from different interventions during this discussion that the role of health professionals and that includes future health professionals is essential towards, you know, creating this approach to digital health. And I would totally concur with that. I think, for example, when we look at what the IFMSA is doing currently, is that we are very much advocating for this evidence-based but also effective and safe approach to digital health. So that's what we are doing, and I know that members of ours are working on their own projects related to this as well. And of course, a more widespread approach is needed. And I would add to that another perspective of looking at it, which is also that when we look at climate change and the contribution of health systems to climate change, health systems actually contribute a lot to CO2 emissions in the world. 4.4% of CO2 emissions are done by health systems. And climate change is also the biggest threat to our health. So as health professionals, we should also ensure that our own practice, you know, looking from the inside, our own practice is more sustainable. And that's another opportunity that digital health provides for us. But I believe that in order for us to contribute well to this discussion, to be at that table, we need to be empowered to do so, and we need to know more about it to do so. I believe a lot of health professionals that I interact with on the workplace do not know a thing about digital health. And we need to ensure that it is the case that we do know about it. And therefore, I believe that education about digital health in the medical curriculum is truly essential for us to actually be empowered to take part in this conversation, because then we actually know what we're talking about. But not only that, also for the health workforce to contribute to both the design, the implementation, and the evaluation of digital health. Because I think with our perspective as health workers, I think that's essential, and we've heard it time and time again in this conversation as well. So that would be my answer to that.
Thank you so much, Iris. And now I will be taking one question from the floor, which has been asked earlier. I don't have the full context of it because of my, coming out and now in. However, it was reflecting on the point mentioned by Dr. Tlaleng regarding accountability and regarding the access to information, and how could that reflect on actually the patient-doctor relationship, and how will it shape that in terms of accountability, but also in terms of misinformation. So I will direct this question to Dr. Marco. In that sense, with digital health allowing maybe more questioning of the clinical decisions, Is it an upside or is it a downside of digital health technologies?
I mean, it depends really. If you assume the perspective of the doctor receiving more questions, probably it's a downside because you will be more questioned by empowered patients that look for the answer to their questions on Google or, you know, other, let's say, non-reputable sources. At the same time, I mean, if the point is to having more educated customers and citizens one day, maybe this is the right way to do. The right way to, so giving access to people, giving access, unlimited access to information is a good sign of people, you know, getting and becoming participants of the decision-making process related to their health. So I see it from this point of view. From a professional standpoint, I'm not a doctor, an MD, let's say from this viewpoint. So I cannot know, you know, how frustrating it might be to talk with the patient that comes with an answer already printed out, let's say on the paper, saying, you know, please give me this prescription because I know that this is beneficial to me. So the risk is always, you need to, from your perspective, you need to understand who you have in front and understanding what brought that question and what made the patient look for this information alone. And probably it's your role in teaching them, educating them about sources of information. And it goes back to the point I mentioned before about health literacy or digital health literacy. Not everyone has the capabilities, the skills to understand how to interpret and how to search for information. Yes, of course, they come to you with a question coming from Google, but that doesn't mean necessarily that information is correct. So it's your role in modifying and correcting that misinformation when it comes. It, you know, makes sense what I said.
Thank you. No, it definitely makes sense. And this is maybe reflecting on the point that digital health does not remove the role of the clinicians, duty of the healthcare workers to create that kind of trust between them and the patient in order to avoid maybe this kind of gap or this kind of.
If I may add here, you mentioned a very, very important factor here, trust. And what we are facing nowadays with the misinformation and disinformation, the infodemic about the COVID-19, is really a matter of trust, the problem of disruption of the way we think. And because technology has the potential also to create and to polarize our opinions, and this has consequences, of course, on the way we access health-related information. Think about, you know, the anti-vaccine movement and the fact that, you know, you cannot convince an anti-vaxxer to take a vaccine unless you force them in different ways, of course. Because social media are supposed to do that, are supposed to reinforce our cognitive biases by design. So this is something we need to consider when we talk about diffusing health-related information online, because we are going to preach the choir if they don't convert it. Anyway, I close here.
Thank you so much, Dr. Marco. Now to just maybe wrap up the panel discussion overall, I would like to ask some take-home messages or messages towards medical students from the speakers. What can, at the end, let's say, what are your messages towards medical students and their involvement in digital technologies and digital?
I'll venture and go first just because I have to leave and get kids from daycare, so I'll apologize for that. But I think, you know, one of the immediate risks is the fascination that happens with new technologies. You know, the fact that you can link a doctor anywhere with a specialist anywhere and, you know, give them advice, and most of it is warranted. Our job as this field emerges is to look at it with a critical eye from a clinician's perspective. Others will think about its viability, about its proliferation, about its, you know, our job is to look at it as a clinician. What is it is different from the best practice that we feel comfortable with? And what is it is similar and what risks it can carry? And that very few others can do with the same perspective. And The other thing is, because we're talking about availability of information, I would suggest that we do not at least discount digitalizing indigenous healthcare and digitalizing indigenous knowledge. So I'll give you an example, and the reason I talk about that, we still assume, again, a biomedical model that is applicable to all people equally, that ignores social, economic, and political aspects, and I don't think that will fly anymore. In New Zealand, the only country that eliminated COVID, at least for a while, now they have a few cases, a big part of that work that has been done is not just the government being cautious and so on, but indigenous communities, the Maori tribes, imposing their own restrictions and controlling the access and the possibility of infection. And I think they've based that on socially and politically and acceptable norms that are specific to them. So I don't think that experience can be taken and planted in Egypt, for example, without but the model of giving the autonomy for community, for indigenous knowledge to affect how medicine is practiced, and making that available and exchangeable and learnable by others is probably a very strong point. Digital health shouldn't be only about clinical guidelines. It should extend to be about the application of medicine in its social and economic and political contexts. And I'll thank you very much, but I really have to leave to get to the creche in time. Thank you very much for having me.
Thank you so much, Dr. Tammam. Thank you so much for your comment and for your valuable insights and perspectives. Thank you so much once again. And Dr. Marco, maybe final messages for the medical students worldwide.
So like recommendations, let's say get involved. So get your hands dirty. So start using technology with a conscious mind. Of course, we said before, you should experiment if you feel like, and having in mind then the uses and gratification theory I said before, thinking about how your patients are using the technology. Don't impose, right? Just ask questions about how are you using technology, how are you using the digital tools that you're familiar with, they might not be familiar with. So probably adapt your style to their style, to the patient style. And I want to also reinforce what Dr. Tammam was saying, be critical. So critical thinking is something that we always have to observe, especially in the context of misinformation, disinformation. And it's always an ethical issue to have here is the benefits should outweigh the risks. Having always that in mind, saying if I use this technology, what are the risks for my patients? Is it better if I do this? Is it safe? Will this create more problems later on down the line? Then by any means, go ahead and use technology. You should really, you're probably mostly digital natives, like Miss Iris was saying. So you're probably more familiar than anybody in the chat here is. But at the same time, it's not about being born in a specific year that grants you automatically the ability to use the technology the right way.
Thank you so much, Dr. Marco, and perhaps final words as well from Iris.
Thank you so much, Mahmood. First of all, thank you so much for the panelists as well and for Mahmood for this very interesting conversation. I've been very happy to take part and learn so much about the amazing interventions here. I would like to say that first of all, I've talked a lot about education and the importance of having digital health in the medical curriculum. Actually, right now, there's very little information out there how much it's already being implemented, and that is something that we want to change. So I hope that you can all contribute to that. I will put a survey in the chat box in which we are asking for medical students from all over the world to contribute their voice to digital health in the curriculum. So I hope that you can all fill that out. I will also make sure to put it on the Facebook chat as well. And in addition to that, I would totally reiterate what Dr. Marco said. I'm very happy that we've had this conversation here. Keep having these conversations, keep being involved in this topic, because that is essential as digital natives, as future health professionals as well. And I would like to mention to you that the theme event of this OGA focuses on digital health, and there will be many very interesting events that are still to come on digital health. And I hope to see you all there as well, so that we can keep this conversation going and also keep applying the very important lens from the human rights perspective. Thank you so much for having me.
Thank you so much, Iris. And once again, thank you so much for all the speakers, for Dr. Tlaleng, for Dr. Marco, Dr. Tammam, and Iris as well, for the insightful, reflective interventions. Thank you so much also for all the participants. I would like to end by saying that, as Dr. Tlaleng mentioned, digital health is only part of a system. No matter how invested it becomes in that system, we need also to, let's say, ensure that the roots of the system are strong, the roots of the system are equitable to everyone, and the roots of the system as well ensure the accessibility, the availability, the acceptability, and the quality of healthcare towards all. With that, I would like to end the panel discussion. Thank you so much for your participation. Once again, thank you so much for the speakers. And with that, I think we move to a break, if I'm correct, Maha, right?